The following slide set includes summary slides on LVAD best practices from Bob Kormos, biventricular support, acute circulatory support, extracorporeal membrane oxygenation, all as background for the Society of Thoracic Surgeons University course. In this slide set, we will review basic and advanced concepts to allow preparation for an active learning environment. The first set, LVAD best practices, are based on the guidelines for the Revive It trial, an NIH LVI trial presented by Dr. Bob Kormos to the investigators regarding the practices to follow for this trial to optimize pump function and decrease the risk of pump thrombosis. Tagavi et al. Published in Annals of Thoracic Surgery in a single-center, small study demonstrated that inflow cannula angle and a shallow pocket were risk factors for pump thrombosis. This data has been corroborated by others and is the basis for pump positioning and anchoring the pump. The angle should be approximately 60 degrees, shown here, and the pump pocket should be below the diaphragm and generous to allow the pump to sit without acute angulation relative to the heart. In addition, Dr. Kormos and others have confirmed the recommendation for deep pump positioning with pump anchoring at the rib cage or below, both laterally and medially. Pump speed management is essential, and optimizing the hemodynamics to allow the cardiac output to maintain proper organ function without jeopardizing the right ventricle. Pump speed should be set above 8,800 when the pump is in stable hemodynamics, with an eye towards minimizing right ventricular dysfunction, but also to optimize flow through the pump and allow pump cooling. Long-term management pump speeds are set between 9,000 and 9,600, with 9,200 being the most common setting in the destination therapy trial. In the Revive It trial, if clinical site investigators set pump speeds less than 8,800, this will be investigated. In general, setting the pump to allow the aortic valve opening is not a current recommendation of these investigators or current practice. Additional guidelines prior to discharge, a transthoracic echo with optimization of speed is recommended. Again, pump speeds less than 9,000 are strongly discouraged. Increasing speed may cause clinically meaningful increases in blood pressure and increased risk of stroke. This is essential to check both prior to discharge and after discharge. Standardization of patient monitoring for pump thrombosis currently undergoes surveillance using biomarkers of LDH, performed post-op day 4 and post-op day 7 and monthly thereafter. In the trial, hemolysis will be based on the definition of the detection of increased BNP, transthoracic echocardiography to assess LV dimension, unloading and valvular function, and or the need for right heart catheterization to assess hemodynamics. High-resolution or 3D reconstruction CT to assess inflow-outflow cannula malposition or obstruction is an adjunct for patients with concerns for pump malfunction. Generally speaking, in the trial, standardization of patient management practices follow the algorithm published by Goldstein in Journal of Heart-Lung Transplantation, where the presence of hemolysis with evidence of hemoglobinuria, heart failure symptoms, or abnormal pump parameters or evidence of organ dysfunction greater than 24 hours, with monitoring and reassessment. The time to diagnosis of suspected pump thrombosis and hemolysis will be monitored. Subjects will not receive hemolytic therapy. Intravenous anticoagulation with heparin, antiplatelet therapy as a bridge to pump exchange has been suggested as permissible. LDH is going to be monitored throughout this trial and is generally monitored in current practice, with expected management of an isolated LDH without clinical signs of hemolysis, heart failure, thromboembolic event. These subjects, however, are going to undergo increased monitoring and surveillance for signs of hemolysis, heart failure, or pump dysfunction. The question of additional valve procedures has been raised and studied by several co-authors, including Milano and co-authors in the HVAD trial, as well as Randomization and others in the HeartMate 2 pivotal BTT and DT trials. In this trial, with an HVAD device, 382 patients in the bridge plus cap received concomitant procedures, a total of 120, 75 with or without other procedures, tricuspid repair replacement 56, aortic valve repair replacement 13, and mitral valve repair replacement in 6. In this study, HVAD procedure alone or plus any cardiac valve procedure, where essential survival was no different. However, when one separated out these and compared them for HVAD plus aortic, shown here in blue, and HVAD plus tricuspid valve procedure, shown in red, again, there was no significant difference in the Kaplan-Meier survival. In this study, in addition, HVAD alone, concomitant valve, plus or minus tricuspid insufficiency, and tricuspid valve procedure, the number of patients with early right heart failure was significantly higher in patients who had concomitant valve procedures as compared to HVAD alone. Late right heart failure, however, was less in patients who received tricuspid valve procedures. When one looked at multivariable analysis for risk factors, tricuspid regurgitation and female gender, both were significant risk factors for adverse outcome. In a separate analysis performed by Dr. Jason Robertson and colleagues, presented at the ISHLT and currently in press for Journal of Heart-Lung Transplantation, looking at concomitant aortic valve procedures in continuous flow LVADs. These authors looked specifically at aortic insufficiency and the presence of a mechanical valve with valve exchange or closure, examining the 3 distinct strategies, including aortic valve closure, aortic valve repair, and aortic valve replacement. These can be done by either a Park or Frater stitch, or coaptation stitch, or other repair methods, complete suture closure with felt strips, as advocated by the San Diego group, aortic valve replacement, or patch closure of the aortic valve of a previous mechanical valve, or the aortic valve or outflow tract. Previous studies have suggested that the mortality is increased, with some studies saying equivalent or improved survival. The largest of these data were Ranji's BTT and DT trial cohort, showing 30 aortic valve replacements, 32 aortic valve closures, and 18 aortic valve repairs. In this study, long-term survival was significantly reduced compared to HeartMate 2 alone, with 1-year survival at 57 versus 75 and 2-year survival at 43 versus 64. In order to analyze this population in the INTERMACS database, the database was queried, looking at continuous flow pumps only, 6,721, with total cohort of 5,344, with a mean follow-up of 12.3 months. In this cohort, aortic valve closure was performed 125 times, aortic valve repair 95 times, aortic valve replacement 85 times, and all other non-aortic procedures, a total of 5,039 times. When one examines the survival by type of aortic procedure performed, we see several trends, highly significant. Number 1, aortic valve closure has both an early hazard and subsequently stabilizes for an increased risk of death. Aortic valve replacement and repair, however, appear to have a similar early hazard, potentially separating late as compared to no aortic valve procedure. Survival for INTERMACS level 1 and 2 by type of aortic valve procedure displays these curves even more significantly, with aortic valve closure again showing a significant early hazard and decreased survival at both 6 months and 1 year, statistically significant, of 67 and 56 compared to 85 and 79, with aortic valve replacement also showing a decreased survival, with repair approximating no aortic valve procedure. This was a highly significant trend. When one then looks at the less sick population of INTERMACS profiles 3 to 7, we see that again the trend is significant at a P04 level, with aortic valve closure and replacement potentially having differences, with repair being less significant. When one analyzes a multivariate model for death after implant, we can see that aortic valve closure is highly associated with increased mortality risk at the level of dialysis or biventricular support. Competing outcomes for patients without an aortic valve procedure, we can see that the 1-year survival alive with the device in place is 60%. For bridge patients, transplanted 23, 17% are dead, and 1% recovered. This is different compared to patients with an aortic valve repair or replacement or closure, and we can see that these patients are alive with the device in place. Similarly, slightly increased death and decreased transplant rate in both categories, more so for aortic valve closure. No differences were observed with respect to time to first stroke, rehospitalization, or right heart failure between groups. Higher rates of renal failure were seen if a patient had an aortic valve intervention was performed, but there were no differences between groups. Overall, aortic valve procedure was more likely to give renal failure, possibly related to an increased pump time. Recurrence of aortic insufficiency postoperatively by group was significantly higher in patients who had aortic valve repair, but still less than 25%. In patients who had either no aortic valve procedure or who had aortic replacement or aortic closure was not significant. The study concluded that aortic valve closure is associated with increased short and long-term mortality, particularly in the more sick patients of Intermax 1 and 2, and this has fewer patients with aortic closure reaching transplant. The reason for this mortality is unclear, but may be related to respiratory failure or major bleeding. It was not detected as pump failure or the lack of a backup pump. Aortic valve repairs, while associated with the lowest mortality, are less durable with an increased recurrence. The question of biventricular support has been raised, and what defines the threshold to initiate mechanical circulatory support? Is it the adequacy of hemodynamic support? Is it hemodynamic criteria, which are not specific? Is it the degree of medical intervention or the degree of vasopressor support? Or is it the end organ response to medical therapy? I suggest that these thresholds and criteria are different from institution and from surgeon to surgeon. The most common scenario to consider biventricular support includes cardiogenic shock, acute myocardial infarction, post-cardiotomy shock, and post-cardiac arrest. In addition, RV failure associated with continuous flow of VADS is an increasing problem, both early and late. And you can see in this algorithm depicting the potential courses of care for patients with severe cardiogenic shock with inotropes, dilators, and or the use of an intra-aortic balloon pump, although not indicated in ischemic events, may have some benefit in chronic heart failure. Revascularization remains a first line with post-pump failure, temporary support in some fashion, percutaneous VAD support, tandem heart or impella, as a bridge to either transplant or recovery assessment. Consider bridge to long-term LVAD, multiple organ failure with neurologic deficit, palliative care versus rehab and a bridge to recovery. Dr. Todd Massey at University of Rochester has a significant series in patients with acute myocardial infarction, cardiogenic shock receiving durable implants, as does the Mount Sinai group, with excellent results, although these indications remain controversial and in evolution. The question of intraoperative assessment of RV failure after placing an LVAD, showing if there are signs of RV failure, volume overload, inotropes, vasodilators, diuretics, and if this is non-responsive, then RVAD placement is key. If there's no RV volume overload, inotropes, and vasodilators, and again, if it's not responsive, RVAD placement. Signs of RV failure include failure to wean from cardiopulmonary bypass, the distended or spherical right RV, central venous pressure greater than 20, bleeding with large volume transfusions, tricuspid insufficiency, new or worsened, septal shift, and atrial arrhythmias. In addition, failure to fill the left ventricular assist device, and adequate flows with moderate to high level support would be considered a standard indication. Survival being the minority of patients, unless transplant is an option. Mechanical biventricular support comes in a number of flavors, and these can include the Thoratec IVAD, PVAD, implantable ventricular assist device such as the Jarvik 2000 HVAD, hardware HVAD, and or temporary devices such as Levitronic Centromag. These can be considered intracorporeal and paracorporeal, extracorporeal. Options for right ventricular support for post-cardiotomy shock obviously include intra-aortic balloon pump, centrifugal pumps such as the Centromag, tandem heart, and the ECMO circuit. Each has a ability variably to provide either biventricular or univentricular support, or in the context of total cardiac support, flows can be greater than 6 liters with centrifugal pumps and ECMO, and variably can be associated with a need for anticoagulation. The intra-aortic balloon pump may not require anticoagulation, as well as the centrifugal pumps in the right ventricular setting. Patients cannot ambulate with these unless they're placed in novel or creative type of arrangements, period. This lists a variety of devices, including the Abiomed pulsatile, the Impella Percutaneous, the Tandem Percutaneous, the Centromag, and the Thoratec IVAD and PVAD. In addition, the Impella RP is undergoing analysis for approval. Similarly, the Tandem Heart dual cannula for right ventricular support has been approved and is commercially available. Triage VADS or percutaneous BIVADS are the wave of the future. Shown here, we have a version of the Tandem Heart pump with a dual lumen system to allow blood to be pumped with or without an oxygenator to the pulmonary artery, and transseptal approach for the Tandem Heart, a early version of right ventricular assist device which could be applied in the operating room, which has evolved, as well as the Impella through the aorta. Cannulation for these devices can be accomplished in a variety of ways, and there are specialty cannulas from the different companies which are long and allow good cannulation with the aid of surgical cuffs, and others to allow cannulation of the pulmonary artery, the aorta, the LV apex, the right atrium, and or the left atrium. So this is really the left atrium and this is the right atrium, shown here for right ventricular assist and left ventricular assist, shown here with the new generation Centromags, as well as the Rotoflow system. Cannulating the LV apex has been facilitated by pre-made cuffs by both Abiomed and Thoratec, and allows adequate decompression of the left ventricle directly with flow through the left atrium and left ventricle to decrease thrombotic risk. Biventricular support is a highly lethal therapy for a higher lethal disease. The majority of patients who survive have undergone transplant, and 40% are transplanted at 6 months in the INTERMACS database. However, an almost equal competing risk of death before transplant is 35% at 6 months alive with any device still in place, and only 4% explanted recovery. So if you receive a BIVAD at this time point, at 6 months, you have only a 1 in 25 chance of being explanted, with almost a 1 in 2 chance of having a transplant. The relative risks for death with BIVADs include older age, higher BSA, presence of ascites, creatinine, bilirubin, and a history of valve surgery and failure to wean from cardiopulmonary bypass. In order to prevent the need for right ventricular assist devices, there have been many different risk scores to help us assess the possibility of right ventricular failure. The right ventricular failure risk score from Michigan by Jen Calgar Matthews and Keith Aronson. All of these have tried to assess the risk with stratifying patients with left ventricular assist device with a high score to decrease survival and a lower score for less. However, none of these are perfect. Again, the intraoperative assessment of LVAD plus and RVAD, the VAD candidate. The preoperative assessment of RV failure is important. However, many times there is no significant way to prevent a need for support at that time. Assess for signs of RV failure. Refer to clinical factors. Look for signs of RV overload. And again, preoperative assessment and preoperative optimization. If the patient doesn't respond to treatment and receives a left ventricular assist device, BIVAD placement is a significant risk. In order to deal with the need for longer-term right ventricular failure, the Berlin group by Hetzer and Thomas Krabich and Dr. Potapov have pioneered a series and suggest this algorithm for left ventricular and biventricular support. With biventricular support, if 3 of the 4 criteria apply, RV short long axis ratio greater than 0.7, in other words, a dilated right ventricle, a right ventricular end diastolic dimension greater than 35 millimeters, an RVEF of less than 30, and a right atrium greater than 50 millimeters. In the presence of 3 or 4 of these, the pulmonary vascular resistance is low. In this case, they favor BIVAD implantation. If the pulmonary vascular resistance is higher, they would go with left ventricular assist implantation, as they would if they were less than 3 or 4 available. This is the chest x-ray for one of the patients with a BIVAD hardware pump with the right ventricular assist device placed, in this case, into the right atrium laterally, with good decompression of both the right ventricle and left ventricle, as seen in this PA and lateral series. Here we have a picture of the patient outside the hospital. This patient is actually a very large patient. He's, I believe, over 6'2" tall. And you can see that the amount of equipment necessary for this patient is very significant. And this is not an approach which would be amenable to a small elderly woman. Temporary right ventricular support in high-risk LVAD patients versus permanent or total artificial heart has been studied by the Berlin group looking at the discharge and survival, and we can see that both methods or all methods of supporting the right ventricle lead to higher short-term survival, but that with delayed temporary RVAD, the survival is significantly less delayed versus primary temporary RVAD and LVAD, delayed temporary RVAD and LVAD, and permanent BIVAD or TAH. And you can see that the survival for these is comparable, except when there is significant delay. Time of implantation is clearly important. So if you were going to do a right ventricular assist device, the time to do it is in the operating room and prior to making the patient struggle. And the question is, does the device really matter? And here we can see LVAD, no RVAD, in the absence of RV failure and the presence of RV failure, data from Bob Cormos' group at University of Pittsburgh Medical Center, UPMC. We can see that survival is significantly decreased. However, LVAD versus BIVAD, we can see that biventricular support, a significant detriment of survival comparable to the UPMC group, and that the HVAD-BIVAD group, again, looking at 6-month data, here has approximately 65% survival. Shown here, 6-month data is approximately 58 to 60 survival, and you can see that it's roughly the same. So within broad categories, there may be some advantage to an HVAD-BIVAD versus a temporary BIVAD, but there does not appear to be significant differences with variation between the populations and the groups. So the question is whether or not there are other approaches, and some have suggested, as this group from Frankfurt at Goethe University, that ECMO as a perioperative right ventricular support with biventricular failure has been a very successful way in this group. And in this group, published from EACTS in 2010, 10 patients who underwent LVAD were analyzed. 6 were supported with ECMO before. 4 ECMO was implanted upon weaning. All patients had RV failure by standard criteria. Some patients had tricuspid insufficiency. ECMO was weaned 4 plus or minus 1 days after left ventricular assist device implantation, and 4 patients expired on LVAD support due to non-device related sepsis, mesenteric ischemia, and GI bleeding. Overall survival again was 60%, and this provided satisfactory. Now this is a lower cost, this is a satisfactory way of doing it, and again we are at the 60% level in the presence of right ventricular failure. They concluded ECMO provided a satisfactory perioperative right support biventricular failure undergoing LVAD, who otherwise were better candidates for BIVAD. ECMO allowed time for the already compromised right ventricle to get attuned to the preload and avoids distension and RV failure. Mortality is high with biventricular support. With any mode of support, planned early support is best when needed. Early institution with full support remains crucial. Decompression is essential recovery. Consider LVAD apical cannulation. Weaning support over 5 to 14 days is likely, depending on etiology, comorbidity, and age. Survival depends on a time to initiation, age, and comorbidities, as well as the physiology, rather than the device strategy. VA ECMO remains an idea and possibility for ventricular support as an effective tool for select scenarios. We transition to ECMO in a presentation by Dr. Sunil Prasad, and the question is raised that most surgeons know a lot about ECMO, but there are things that we all could learn and finesse our knowledge. ECMO has many parts. There's the pump, there's the tubing, there's the oxygenator, there's the controller, there are the stopcocks, the blood, and anything else. The aspects here that are important to consider are that every ECMO setup is different. And the ECMO setup in your institution that you use may or may not be standardized, and it may or may not be altered by the perfusionist when it is set up for various reasons, and can be and should be considered to be a flexible tool for cardiopulmonary failure. ECMO versus cardiopulmonary bypass, and while ECMO is based on cardiopulmonary bypass, ECMO is certainly different, and it can be intimidating. Some can say scary and some can say sexy. And so taking the cardiopulmonary bypass circuit out of the safety of the OR and putting it at the bedside is exposed to all and run by a clinical team for the ICU, not a clinical team for the operating room. When did ECMO start? Well, it started with the development of cardiopulmonary bypass. The direct blood gas interface was used for oxygenation for cardiac operations, but it was also used for respiratory failure and cardiopulmonary failure. And the short-term sequelae, with activation of the complement system, platelet activation, white blood cell inflammation, and hemolysis, all occur to varying degrees in the initial cardiopulmonary bypass system, leading to both foam and microbubbles in the direct gas, blood gas interface. Prolonged extracorporeal oxygenation for post-traumatic respiratory failure was described by Donald Hill from the University of California at San Francisco in the New England Journal of Medicine in 1972. Shown here, peripheral ECMO cannulation system for perfusion for a 24-year-old man who had a transection of the thoracic aorta, multiple orthopedic injuries from blunt trauma. The aorta was paired, but respiratory failure occurred, and despite maximal support at that time, the heart-lung machine was initiated and continued for 75 hours. This patient ultimately survived and was weaned from cardiopulmonary bypass. ECMO cannot be mentioned without mentioning Dr. Bartlett from the University of Michigan, who treated neonates with 75% survival versus 95% predicted mortality, shown here with one of his original ECMO patients. 5 different membrane oxygenators for ECMO were manufactured and used, and many different practices and protocols were made akin to the Wild West. In 1978, the Biomedicus Biopump disposable centrifugal pump became commercially available as an alternative to the roller pump for cardiopulmonary bypass, and use was almost begun immediately for ECMO. In 1979, the NIH study of ECMO was performed after anecdotal success from the early 1970s. This was NIH-sponsored, multi-institutional, prospective, and randomized. These are patients with acute respiratory distress syndrome, bacterial pneumonia, viral pneumonia, pulmonary embolism, and shock lung. They were randomized to veno-arterial ECMO or ventilator standard management. In this NIH-sponsored study of ECMO in ARDS from 1979, you can see that the ECMO patients shown, the control patients shown here, and the ECMO patients shown here had similar survival. An additional data collection of 625 patients shown here had improved survival. This was published in the Journal of the American Medical Association in 1979. This was stopped after only 90 patients. Authors concluded there was no benefit of ECMO at that time, and the use of ECMO in adults all but stopped. Neonatal ECMO, however, continued, and in neonates, children, and adults from 1970 to 1980, we can see that the neonates had exceptional survival as compared to both children and adults, with 55% of the neonates surviving in this series from UCI. The University of Michigan again advocated for more data collection and had an ethical dilemma and a randomized trial that was again initiated. Patients were randomly assigned. If one treatment proves to be successful, the chance of getting assigned increases. One ECMO patient, one ventilator, the chance was 50-50. Consent for the study was only for ECMO patients. Conventional patients never knew. Families would be distraught not receiving the latest technology for their babies and would desire to cross over. So only the experimental arm was actually consented. The first baby randomized to ECMO and survived. The second baby to ventilator management and died. And then it was randomized. The next 10 babies were randomized to ECMO. All survived. The study was stopped at 11 babies, statistically significant. Neonatal ECMO study at the University of Michigan, prospective randomized from 1982 to 1984. Bartlett and Ruloff, Pediatrics, 1985 was published. 50 respiratory failure patients, 36 improved, 14 were unresponsive to therapy, 12 were randomized, 11 ECMO, all survived, 1 conventional died. So ECMO was significantly better than conventional therapy for this at a P level greater than P is 100,000. 1989, Boston Children's at Harvard System, cardiac surgeons began using ECMO and pediatricians for conventional therapy, and again randomized trial. Phase 1, strict randomization until 4 deaths in either group. Phase 2 only receives better treatment until 4 deaths. The Boston Children's Hospital neonatal ECMO study, randomized from 1986 to 88. O'Rourke published in Pediatrics in 1989. 19 patients, conventional RX 10, 4 died, 60% survived. ECMO 9, 0 died. ECMO 20, 1 died for 97% survival. Interest was again Rekindled with experience for ECMO in adults, and the Cleveland Clinic published experience with 202 adults receiving ECMO for cardiac failure survival at 5 years, and they showed while survival up front was significantly less than ideal, patients surviving 30 days had a 64% chance of surviving 5 years, and they concluded that extracorporeal membrane oxygenation is versatile and salvages some patients who would otherwise die. Improvement in intermediate-term outcome requires a multidisciplinary approach to protect organ function and limit organ injury during the support. The CESAR trial was mid-2000, 180 patients, 18 to 65 years, with a Murray respiratory failure score of greater than 3 or pH less than 7.2. This was a randomization to ECMO versus conventional ventilation, and exclusion with peak pressures greater than 30. This was the Murray lung injury score at that time, the chest X-ray, alveolar consolidation, quantification, hypoxemia, P to F ratio, decreasing P to F with an increasing number, PEEP score when ventilated, again higher PEEP, higher number, respiratory compliance with less compliance and a higher number. The final score is calculated by the addition of these. A score of 0 is no lung injury, 1 to 2.5 is mild, it's a moderate lung injury, and greater than 2.5 severe lung injury. In the CESAR trial, 63% ECMO referral arm and 47% conventional, and you can see here that ECMO had a significant advantage relative to conventional management. However, this was an intention to treat, and patients were included in the ECMO arm that did not actually receive ECMO, but merely were referred. Lastly, most recently, the epidemic of H1N1 led a New Zealand group to publish their experience with ECMO in 2009. 68 patients with influenza H1N1 were treated with ECMO, of which 61 had either confirmed influenza A H1N1 53 or influenza A not subtyped. An additional 133 patients with influenza received mechanical ventilation, but no ECMO in the same units. The 68 patients who received ECMO had an age of 34, and 50% were men. They had a lung injury score of 3.8, and the duration of ECMO support was 10 days at a range of 7 to 15. At the time of reporting, 48 of the 68 patients, 71%, had survived to ICU discharge, of whom 32 had survived to hospital discharge. 16 remained as hospital inpatients. 14 patients had died, and 6 remained in the ICU, 2 of whom were still receiving ECMO. Severity of ARDS before commencement of ECMO, and you can see that these patients had a very low P to F ratio on 100% oxygen, with high levels of PEEP and high peak airway pressures. These patients would have been excluded in the CESAR trial at that time, with a pH all in the range of the patients in the CESAR trial, with highest PaO2s only in the 60s, and tidal volumes 5.6 to 5.7 mLs per kilo, with 4 out of 4 quadrants of radiograph infiltrate and lung injury score all in the severe range. Significant percentage had pneumothoraces. Rescue therapy had been trialed. Predictors of morbidity and mortality with ECMO included age greater than 70, obesity, persistent anaerobic metabolism after ECMO support, acute and liver and renal failure. Diabetes, again. Predictors of in-hospital mortality, device insertion under cardiac massage, 24-hour urine output, and female sex, myocarditis. These are predictors of morbidity and mortality for veno-arterial ECMO for cardiac failure. Types of ECMO include veno-arterial, peripheral, veno-venal, peripheral as well. Cannula can be inserted through the femoral artery or vein and or advanced under fluoroscope or echo guidance to the heart. Internal jugular cannulation can be performed for VV as well as subclavian when necessary by femoral approach. All of these are shown with the CardioHelp device, a self-contained device for ECMO. VV ECMO, as mentioned, can be performed through femoral venous cannulation with the cannula inserted up until the hepatic IVC and arterial return to the IJ. This can also be done as multiple venous effluent with return to the heart with VVVA. VVA can also be done through the femoral with drainage from the IJ femoral vein to the right atrium and blood return to the femoral artery, or VAV, which is performed with drainage from the femoral vein, IVC, and return to the femoral artery and the internal jugular. These specific configurations can be used for a variety of disease states and provide differing levels of both cardiac support and respiratory oxygenation support. Recirculation is one of the problems with veno-veno ECMO, in that with return to the venous system, the oxygenated blood return to the right atrium from the IJ in this circuit can be then drawn out through the venous cannula inserted in the IVC. This is represented by the very blue blood and the lavender blood, which represents mixing. The position of these cannulas, the flow, the relative drainage, the volume status, and right ventricular function can all contribute to this. In addition, recirculation can also occur in this setting with veno-veno ECMO in the femoral system, allowing proximal drainage and distal return. Complications with ECMO are frequent. Vascular complications can result in 80% mortality, bleeding complications same. The Sears response is variable in patients and can lead to greater than 50% mortality. Air embolism, pump failure, and or embolic events can lead to 100% mortality. Thrombus in the circuit and infection are all complications which can increase mortality and decrease survival. In addition to the vascular and bleeding complications, neurologic complications can occur even with strict venous circuits with minimal anticoagulation. Why we do ECMO: technology is greatly advancing, pumps are changing, and oxygenators are very efficient. ECMO pumps are expensive, but they also work very well. Cannula are getting smaller and less thrombogenic, and ECMO from 2000 is different than ECMO of 2014, which is obviously very different than ECMO in 1985. This is a patient, KJ, who was a 31-year-old female, presented with a history of rheumatic heart disease, a mitral valve replacement in 1995, a mechanical valve 23 millimeter, who had respiratory failure after a transfusion for an ovarian cyst torsion, which led to bleeding. She was transferred from an outside hospital. Patient on presentation had a BNP of 149, was managed on a cyst control volume rate of 20, a tidal volume of 300, a PEEP of 10, FiO2 of 60%, IDE 1 to 3.3, pressure is 21/14, and a blood gas is 745/37/86 PO2, and a bicarb of 27 on the first day in the hospital. Her chest x-ray shows areas of consolidation and patchy edema, as well as sequelae of her previous cardiac surgery. The CAT scan on day 2 showed significant progression with dependent consolidation and worsening pulmonary edema. On the 4th day in the hospital, she received an echo. She had a normal left and right ventricle. She had severe AI, a normal mitral valve with a gradient of approximately 10. She was changed to pressure control, rate of 20, a PEEP of 10, FiO2 of 60%, drive pressure of 22, and at which point her blood gas, she became more hypoxic with a pH of 7.4, PCO2 of 33, PO2 of 57, and a bicarb of 22. Chest x-ray showed worsening consolidation, as did her CAT scan. The next day she had complete whiteout and had increasing oxygen requirements with a higher oxygen gradient and a P to F which was decreasing. At 11 o'clock on day 8 she was on 100%, a rate of 40, a PEEP of 12.5, a drive which was 30, IDE of 2 to 1, a peak of 44. She was started on Flolan and nitric. Her pH now was 7.15, her PCO2 was 68, and her PO2 was 69. She was placed on extracorporeal membrane oxygenation, cannulated in the right IJ and femoral, and her oxygen requirements significantly decreased. Her drive pressure was less. Her oxygenation was improved. She was on 4,300 RPMs, 100% FiO2, a sweep of 4 liters, and a flow of 4.3 liters. Her chest x-ray showed slow improvement by day 15. The drive pressure was decreased, increasing oxygenation and FiO2 down to 21%, a sweep of 0.5 and a flow of 1.5 liters at 2400 RPMs. Her chest X-ray cleared significantly. On day 18, her ECMO was removed, her oxygenation was stable, her FiO2 was 40%, and her X-ray had cleared remarkably. However, the next day she developed recurrent pulmonary edema. ECMO was reinitiated with resolution of her pulmonary edema again, and she was taken for a reduced sternotomy with an aortic valve replacement for severe AI and a mitral valve replacement with mitral annular enlargement and decannulation of ECMO. And on day 30, she was on trach collar trials. This is a second case of a patient presented as a 35-year-old female. She was a local university administrator, had no previous medical problems. She was acutely ill and was admitted to a referral hospital and transferred to our cardiac care unit on day 1. Her chest X-ray shown here on day 1, showing mild edema. She was diagnosed with viral myocarditis, started on steroids, subsequently developed acute shock with renal failure and liver failure, and emergently went to the cath lab for an LVAD placement. She developed progressive respiratory distress, now on dialysis. You can see the impella placed here down to the LV, the Swan-Ganz catheter, and significant pulmonary edema. She received 7 days of ECMO support, but the impella remained in place and was ultimately decannulated from both the impella and ECMO with significant resolution of her cardiac function and good myocardial recovery.